Welcome to Urgent Care Grand Rounds. I am Britt Guest.
And I'm Scott Kobner. How are you doing, Britt?
I'm super awesome. I'm really excited about this show because this show is different than any other show we've ever done. You want to know why?
Why? Why is it?
Well, because usually we mix up the topics. We do some peds, we do some ID, we do some cards, but tonight it's all pediatrics.
All crying babies. That's it. We're just going to play a 20-minute clip of crying hysterical babies.
I tried to have crawling babies, but I was vetoed. Yeah, so it's all peds. Super excited about this one. Let's talk about some EMRAP headlines. The EMRAP team, there's always something new going on. There's actually always like 10 things new going on. One of those big things is EMRAP is going to be at ASAP. We are going to have not one but two booths. We're also going to have a 3-hour show, but there's really going to be something going on for like all 4 days of ASAP. So come check it out. We're really excited, reconnect with the community, be out there at ASAP, and it's going to be an awesome time.
It's going to be incredible. We hope to really up the ante with live education and just really connect with everybody. We're going to have both an urgent care area, we said the two booths, and an emergency medicine one. So no matter where you practice on the acute care spectrum, come check it out. We're going to definitely have some sweet swag as always. It'll be fun to put some faces to names out there. It'll be great to see you all.
All right. What else do we have coming up?
This week we have a really fun event for those of you in emergency medicine who are watching. Maybe you're a fourth-year med student. Nervous, that July 1st start date.
I was terrified.
Right? You're about to be a big, bad intern. Or at least you think it's big, bad. Everyone
and a doctor.
Yeah, and a doctor. And a doctor. First time ever writing that prescription for Tylenol. It's going to be really exciting. But anyways, we have the Residency Jumpstart event this June at 5 p.m. June 8th at 5 p.m. Right on our YouTube channel, right here. So you can just click down below in the doobly-doo link, subscribe, hit the little bell, not to miss it. It'll be a really fun live panel. We're going to have a lot of expertise from program directors, nurses, residents, just sharing their experiences about becoming an intern and giving you everything you need to succeed in the months ahead. It's going to be a really fun time.
Nice. Awesome. I love that. And our faculty tonight, like I said, we've got some PEM specialists, so EM and emergency medicine. We have Ilene Claudius and Sarah Christian-Kopp. And of course, we have Mel Herbert. Woo! He's in the house.
I heard roaring applause. Roaring applause. Love it. And of course, we're also joined in one shape or form by our outstanding host of our UC Max podcast. Britt, I believe you had a chance to sit down with Mike Weinstock earlier and record a little bit of segment. And we got Gita Pensa in the chat tonight. That's awesome. So get all of your urgent care questions answered.
She's there, live in the chat.
Right in the chat box. It's right on that side of the screen.
Hi, Gita.
Yeah, it'll be great. Hi, Gita.
All right, so what's next?
So we've got our first segment tonight. It's going to be really fun. A little bit of a game. You know, it's tough. You have kids coming into the urgent care. You don't know what to do with them. Do you have them stick around? Do you treat them a little bit?
And kids are terrifying.
They're terrifying.
They are not just tiny humans. Or tiny, well, they are tiny humans. They're not tiny adults.
They're tiny aliens.
They are tiny humans, that's true. But we can't just treat them like little adults. That's what I was trying to say. There was
our first segment is going to be transfer or keep. Looking forward to it.
UC Max, I do not appreciate the not-so-subtle analogy of human patients navigating the healthcare system and the industrial processing of produce. Patients are not produce, and to imply that you're,
All right, everyone. So now we're going to play a little game called Transfer versus Keep. And I think, as Scott was saying, peds can be intimidating. And you see this sick little kid and maybe they're okay, maybe you're not sure, maybe you're missing something terrible, maybe they need to be transferred to the ER. So who do we transfer? Who do we keep at urgent care? And to go through this, we have Sarah and Ilene. We're going to talk through just a couple clinical vignettes and really get your guys' thought process on why you would transfer and why you might keep them at the urgent care. Are you ready for your first clinical scenario? All right, we have this lovely tongue laceration. This kiddo, he was jumping on the bed, accidentally bit his tongue. Mom's kind of freaking out because it's bleeding like crazy. Transfer to the ER or keep in your urgent care?
I am gonna say keep.
Ilene?
Can I see the other side of the tongue? I want to see if it's through and through because it's gonna make a difference.
All right. It is not all the way through.
Okay. In that case, the T's for tiny human, right? Yeah, okay. No, just kidding. I'm going to keep them.
Okay, keep. So keeping in the urgent care, how do you guys decide which tongue lacerations that can go home safely, which ones need to be repaired? Because that looks kind of bad.
Yeah, so these actually heal really, really well.
Okay.
The only ones that you actually need to work on are ones that go through and through.
Okay.
Obviously, if there's any uncontrolled bleeding, and then a lot of us will transfer for any fissured tongues at the end. Those need to
Meaning
be
that goes
repaired.
like through the tip of the tongue.
Yeah.
Okay.
A lot of people will sew them up if they're more than 2 centimeters. I think you kind of have to use your judgment. How big is the tongue? How big relatively is that 2 centimeters? Is it gaping open? I will say I hate sewing up tongue lacs. It is
Right?
so difficult. And sometimes you have to put like a silk suture through the tongue and pull it out like a tongue stitch. They don't respond that great to sedation. So I love that I have the option in most scenarios of not sewing them up.
Okay, I love that. And I should have said this from the beginning. There is a polling question in the YouTube chat. So everybody can answer these questions with our experts, whether they would keep, whether they would transfer. And it sounds like everybody is agreeing. 90% of the audience said they would also keep this patient, treat them supportively, and send them home.
Absolutely, and you have to give them good discharge precautions, right? Like no crumbly food, you don't want anything caught in that. You have to tell
Popcorn
the parent.
is a no-go?
No popcorn, absolutely no popcorn. You want to give them the Paradex washes
Yeah.
and then let them know that it's going to look like a big, nasty white cankersaur when it's healing,
Right.
so that they're not worried that you should have sewn it up or that you've missed something.
Perfect. So this paper I thought was actually pretty interesting. It's not a huge study, but they took a lot of tongue lacerations. They took a picture before and a picture after and kind of looked at how they healed. And basically they concluded, which I think is more or less what you guys are saying, unless it's huge and gaping and over 2 centimeters, or there's uncontrolled bleeding, or it's involving the tip of the tongue, probably don't need to suture it, and these do just fine. In this specific paper, they kind of have a little diagram here, which shows tip of the tongue needs to be sutured. Side of the tongue depends on how big it is. And again, in the center of the tongue, as long as it's not gaping, as long as it's less than 2 centimeters, and it's not through and through, probably will do fine. All right, ready for your next case. So this is a 6-month-old. They've had 3 days of cough. They have a fever, congestion. Here are their vital signs. Their O2 sat just on room air is 91%, respiratory rate 22, fever is 39, and blood pressure 90/60. I will tell you, because I know you are both going to want more information, the kid overall looks well. You don't see any intercostal retractions or belly breathing. There's no grunting. Generally, the kid looks good.
What are you going to keep?
I think I might transfer this kid.
Okay, let's hear why.
So I think I'm going to keep him at least for a little bit and try to work on maybe nasal suctioning him, see if I can get that saturation improved. Because the only thing that's really abnormal here is he's got a fever and he's a little bit hypoxic, and it's mild hypoxia. He's got normal lungs, he's not working to breathe.
Right.
You're just not going to do a ton with that in the ER. You're not thinking pneumonia because you don't have any findings on your lung exam. So I think I'm going to see if I can fix it with just some nasal suction, and then just kind of watch where the saturations go. And honestly, if it doesn't drop below 90, I might still send them home.
All right. Ilene?
You know, I have 2 things that I'm worried about. The first is that you're saying the lung exam is normal, which is fantastic, but I want a child with bronchiolitis and hypoxemia to have an abnormal lung exam. I want you to tell me that this kid sounds like a washing machine, that there are some wheezes, that this is the classic child with bronchiolitis. You're not giving me that. And so I am kind of thinking, why is this kid 91%? Maybe I do need to do an x-ray or something like that. The other thing is, you know, depending on what country you practice in, here it's recommended that if it is bronchiolitis, we're going to start oxygen and admit at 90%. A lot of other countries will do 92%. This kid's kind of
In the
dancing
middle a
with
little bit.
90, right?
Okay.
And I'm not saying that you need to leave somebody on a monitor constantly and then admit them if they pop below 90 for a hot minute. Of course, you don't want to do that. But I do want to see what happens when this kid eats, when this kid sleeps. Like, what is the progression during the times that your oxygen saturation is at its lowest? Because if you're 91, perfectly awake, sitting up, looking at me playing, what are you going to be asleep? Because if it's a pretty hard 86, that's coming into the hospital.
I mean, I think both sound like pretty fair, and I'm sure if your kid doesn't perk up with the suction and maybe gets a little worse, then transfer. So it's kind of like watch, observe, do an intervention, see how they respond. Cool. All right, so the audience said, okay, let me see if I get these numbers right. 36% of you would transfer, 64% of you would keep. So they're also, the audience is also split. It could go either way, and you probably just need to observe the kid a little bit longer, see how they do with some interventions.
A lot of it depends on your capacity, X-ray, time that you have to
Yes.
observe the child, monitoring capacity that you have in your urgent care, and that's
Right.
going to be different for everybody.
Totally. All right, ready for number 3. All right, so this is an EKG of an 8-year-old female. She was standing in the lunch line at school. She had a brief episode of syncope where she did lose consciousness, and now she is sitting in front of you in your urgent care. Vital signs are stable. She feels fine. She has no complaints. What are we thinking?
Where is send home immediately? I want that one. Is that on my paddle?
Okay, so you guys want to both send her home, but I'm looking at this EKG and I am thinking there are some really big T-wave inversions. What is up with that? That doesn't seem normal. I'm kind of worried. Should I not be worried?
Yeah, I'll take that one. So no, this is actually a normal pediatric EKG. You can have T-wave inversions across your precordial leads.
Okay. And is it allowed to be just in V1, V2, V3? What if it extends out to like the inferior leads? Do I get more concerned then?
It can go through V4.
It can go through V4.
V1 through V4 is reasonable.
Okay, but if it extends out, especially in the inferior leads, that's maybe not the kid I'm sending home.
It's a little bit less common.
Yeah,
Okay.
yeah.
She's a tiny human.
Well, she's 8. All right. So let's see. Did the audience respond to? Nope. Okay. So moving on, we're going to keep or just send them directly home. All right. This is a little kiddo who came in. Dad is concerned that he swallowed a foreign body. So you get some x-rays, and in fact, he did. Are we worried? Do we transfer? Do we keep? Two keeps. Okay.
Oh, wait.
No, wait. A transfer. A transfer and a keep.
screwed up.
I love that the decision is split.
I feel like we should fight it out. Can we just fight it out with the
paddles? Okay, so I'll go Sarah. Why are you going to transfer this person to the ER? What are you worried about?
So,
first of all, what did the kid ingest?
Yeah, so this looks like a button battery ingestion.
Okay.
These are super dangerous if they are still stuck in the esophagus.
Definitely.
Because you can end up with erosion and tracking and perforation and liquefaction necrosis.
Okay.
Once they pass into the stomach, it's much less dangerous, but the risk still isn't 0. And on this x-ray, you can't actually tell if it's still in the stomach or if it's passed into the small intestine. So some GI physicians will go after these if the child is younger and the button battery is a larger button battery.
Okay.
That's why I would transfer.
But Ilene, you're doing the opposite.
I know.
What are you doing?
I'm just trying to be difficult. I'm trying to be a rebel. No, I mean, to me personally, it's past midline. So I think that this probably is intestinal at this point. I think it's made it to the duodenum.
Okay.
Which means if the child is asymptomatic, now a totally different story. In a symptomatic kid, in a kid that swallowed a button battery and a magnet, 2 magnets, obviously that's not the case here.
Right.
That kid is definitely getting transferred.
This kid looks
But
good.
Asymptomatic, well-appearing child in the intestines goes home with like a 2-week repeat x-ray and good precautions. Even if it is in the stomach and the child is asymptomatic, most of the time you can sit on that for about 4 days and then have them have a repeat x-ray.
Okay, so if it's in the stomach, it's kind of debatable, but some GI doctors will go after it. And once it's past there and they're completely asymptomatic, we just kind of wait for them to poop it out. All right. So audience, I think it was 62% of you said you would keep this patient in the urgent care, and then the rest of you would send it, so kind of split again. I started going down a little rabbit hole of these button battery ingestions, and really, I mean, it is crazy. I feel like there's more and more education on how dangerous these are, but the trend from the National Battery Institution hotline shows that more and more kids are ingesting them, and more are fatal ingestions. I mean, if they're in the esophagus, this is like really extremely dangerous for these kids. So there's more ingestions, more fatalities. So we're definitely probably going to see this more and more in the urgent care. So we've got to be looking out for those. I know it's hard to see this. We're going to put this in the show notes, but this is kind of an algorithm you can go through whether or not the patient's symptomatic, how big it is, where it is, and how you need to manage that. All right. So our next image is an x-ray. This is a 6-year-old. He's on the monkey bars. He fell because everybody falls off the monkey bars and breaks something. And he is presenting with left wrist pain. And this is what you see. Transfer or keep?
Keep.
If I have the capability to splint this kid well in a
Okay.
sugar tong,
Okay.
I would keep them.
So if you can, so what would be a reason why you would transfer them? Other than like, is it just the splint alone?
For me, it would be whatever my local orthopedic preference is.
Okay.
So if I know they're going to be following up at, say, the local academic center, and I know that the ortho residents prefer that the patient be transferred so they can maybe push on it a little bit and formally cast it right there in the ER and get it done, where we can sedate and do whatever they need to do, then that one would be transferred. If I know that the kid has, a pediatrician and I, have a ortho that can follow them and I can get them in a day or two and they can be casted in the office, then that kid would go home.
And obviously, we're assuming that this is a closed fracture.
Yes.
And this child is neurovascularly intact.
Yes.
Clearly, lack of any of those would get the
Transfer.
kid sent to the ED very, very quickly. There are probably some places that don't have appropriate splinting material for a very young child, and so that would be the other big thing for me. I think this does need very close follow-up with an orthopedist, but in terms of immobilization right now, as long as you can immobilize it properly and just assure that there's none of the emergencies that we talked about,
Yep.
this child should be okay to follow up with an orthopedist.
All right. And literally 100% of the audience agrees with you because 100% of the audience would keep this patient in the urgent care, splint them, and get them close follow-up. I should have said yes. He is neurovascularly intact. It's not an open fracture. He otherwise looks great. He didn't bonk his head, nothing else. Okay, so this is our last case. This is a little baby, 28-day-old female, coming in with a fever of 39 degrees Celsius and a positive urine. Transfer or keep?
Depends.
All right, so why are you transferring this patient, Sarah?
So before the guidelines changed, I think most of us that trained before that time, this was like the full workup.
Right, and the guidelines just changed in 21?
Just recently, yeah. So I do think that some people in my age range still do the full the full workup.
A full workup being
The lumbar puncture, blood culture, CBC, urine culture.
admitted for IV antibiotics.
Yeah, IV antibiotics and meta. So I think it's reasonable to still do that. Now that the guidelines have changed and you can, there's a 1 week period where now basically you don't have to do the full septic workup right from the beginning and you're just going to get like your urine first and your inflammatory markers and your CBC, that you do have an option now because the urine's positive, right? But the other thing that's going to be tough to do is get a blood culture that can be followed up appropriately with good time management and also get inflammatory markers.
Yeah.
And then, depending on those inflammatory markers, then can you do a lumbar puncture at your urgent care? And do you really want to spend the time doing a lumbar puncture at an urgent care where you may have 15 people waiting in the lobby?
Is that why you were twisting your paddle on the transfer keep?
Right. I mean, it depends on your capacity.
Yeah.
I love lumbar punctures. So if I have the ability to do a lumbar puncture, I might try to keep this child, but we agree on the workup.
Yeah.
So a kid in this first month of life that has a positive urine has the same risk of meningitis as a kid who doesn't have a positive urine. So you're still going to do the whole thing. You're going to do your blood culture and your inflammatory markers. If those inflammatory markers, your procalcitonin, your CRP, your ANC are all negative, then if you don't decide to do the lumbar puncture, typically you would admit in this 22 to 28 age group. But if you do the lumbar puncture and that is also negative, you could potentially send this child home on oral antibiotics.
Right.
So I don't know if everyone is going to want to take the time to do this in an urgent care setting,
Right.
or has the holder or has the rapid access to labs.
Yes.
But that's the workup. And if you are able to do the workup, and I love to do that workup, then you could potentially send the child home.
Right, and so I think that is the question, and we all know that a lot of different urgent cares have variable access to these labs. So I will say that the polling really agrees with just transfer. 92% of these people would transfer to an ER. I think, you have to be able to do the inflammatory, well, you have to do the UA, you have to do the inflammatory markers, and then if you do the LP, you have to be able to get the LP results to say that they can go home with just close follow-up. So I want to talk about the guidelines because this is the clinical practice guidelines for the evaluation and management of a well-appearing, because again, if this kid looks sick, that's a whole nother story. That's a septic kid, they're going. A well-appearing febrile infant. So I just wanted to point out that, as Sarah was saying, this used to kind of be like the first month of life. You have a fever, you get the whole thing. But now they're cutting that to 21 days. That's when we kind of get that whole workup, LP, admit for IV antibiotics. we're talking about kind of that 4th week of life, I guess. And so our kid falls into that with the 28-day. So even if they have, and please correct me if I'm wrong, they have a positive urine, you still need the inflammatory markers. If the inflammatory markers are negative, you don't have to do an LP. But if you don't do an LP, they need to be observed overnight. Is that correct? So if we're doing that, then we need to transfer them. So really the only way the kid could stay in the urgent care is if you have all those labs, you can do the LP safely and that's negative, and then they can go home.
Right.
Did I get it right?
You did.
It's very complicated.
It's so complicated. But I had to create my own urgent care where I have all the capacity I want. So.
Well, wouldn't that be amazing? The Ilene urgent care. All right, so thank you guys so much for playing. That was amazing. Scott, what do we have next?
Yeah, I'm 100% transferring that kid 100% of the time. That
And 100% of the audience
That's what I mean.
almost agreed.
Yeah, that was great. That was a great discussion. Just praying that my next urgent care shift, a neonate that has a fever doesn't come in. Anyways, our next segment, really excited for this. Britt, you had a chance to sit down with Mike Weinstock over some of the images of the evening. These are some things that you'll probably see on an upcoming urgent care shift. I'm excited to hear your thoughts. Let's cut to that now.
It was all a dream. It was all a dream.
All right, Mike, thank you so much for sitting down with me to discuss a couple clinical images of the evening. The first one we have is this X-ray. Let me give you a little bit of clinical context here. This is a 13-year-old kid, fell off some monkey bars playing around at school, and now is coming in with a lot of elbow pain, swelling. When you see this X-ray, what are you thinking?
Well, the first thing I'm thinking is I don't read tons of elbow X-rays. And I want to make sure that I think to myself when I'm doing something that I don't do commonly, I want to make sure that I really do it in a pathwise type of fashion. And so I want to think of what possibly could be going on as well as looking at it from an anatomic perspective. So the first thing that I'm looking for is obviously a break in the cortex, right? If there's a fracture. I'm looking to make sure the bones line up if there's some type of dislocation. And of course, we're assuming that we already did the exam and patient's neurovascular intact, etc. But the curious thing about the elbow X-ray is that sometimes you see secondary signs of a fracture. And so I'm going to specifically look, and I could specifically document also the fat pads. And the way I like to think of it is that the anterior fat pad, in other words, anterior to the humerus, is something that you can see sometimes, but if it's elevated, and that's the sales sign, then that's pathologic. That's something that could be indicative of a joint effusion, joint bleeding, that could be elevating that fat pad, indicating to us that there's a fracture. And then the posterior fat pad, and the little mnemonic, because we also love mnemonics that we can actually even remember, is that posterior is pathologic. If you see a posterior fat pad, that's pathologic. And for folks that really don't read elbows almost ever, that's that darker area, that sort of lucency that's right at the distal part of the humerus. And so you can see anteriorly, you see that dark area right next to the bone, and posteriorly, you see that dark area right next to the bone. So those are the things I'm looking for. But Britt, there's another way to also look for a fracture if you don't see one of those overt fractures or a specific break in the cortex or a disruption in the lining up of those trabecula of the bone.
Yes, absolutely. I think this is a really good X-ray because it's really subtle. Like those fat pads that you're talking about, you see an anterior, you see a very small posterior pathologic. So there's got to be a fracture there. The other thing I think about is the anterior humeral line. So that's a line drawn along the anterior aspect of the humerus. And that line basically should intersect the capitellum in the middle third of the capitellum. If you look closely at this X-ray, you'll see that that anterior humeral line actually intersects the capitellum in the anterior third. So it's shifted a little forward, which is a sign to me that there is a fracture, and I'm worried about a supracondylar fracture. What about you?
I agree. And with medicine, we always default to the more potentially serious thing, right? So if a patient has, a facial droop and unilateral numbness, well, it might not be a stroke, but that's what we always think that it could be, right? And in the same way, and this is a really important point that you make, is that the patient needs to understand, first of all, in this situation where it's likely a fracture because we're seeing secondary signs, but in addition to that, even if this looked normal, but they had significant pain or a very concerning mechanism, treating it as if by immobilizing it and then having that patient follow up with the understanding, and really every x-ray that we get, the understanding that it still could be a fracture, even though we don't specifically see it on 2 or maybe even 3 views, is a very, very patient-centric way of dealing with this type of thing. Because sometimes, again, an osteopenic patient for a hip, just for example, you might have a patient with a fracture that you just can't see and only see these secondary signs.
Okay, Mike, are you ready for clinical image number 2?
Yes.
All right. So this is another patient. This is a 10-month-old. It doesn't really need too much more introduction other than it's coming into your urgent care with a rash.
So there are certain patients that have presentations that we can, even before we see them, be pretty well assured that we're going to get the diagnosis right, or maybe narrow it down to several different things. For example, dermatomal rash of vesicles on the erythematous base that doesn't cross the midline. If a patient describes that, we're thinking pretty much that's zoster. Or, you're working out in the yard and you have an itchy rash, probably poison ivy, right? So in the same way, they come in with an infant and they say there's a rash in the diaper area. But diaper rash is a little bit of a platitude type of way that you could say something because it could mean different things to different people. So the first thing that I'm going to do, just so I don't zero in and anchor onto one of these possible things, is to make sure that something else isn't going on. Of course, I'm going to want to really take a good look at it, but making sure there's nothing like a perianal strep infection, making sure there's no signs of trauma or abuse, making sure that this actually is a rash and not something that is, petechial or from ecchymosis from trauma or some sort of infection. However, assuming that it's what we think it is, my differentiation, Britt, usually is between a fungal infection or some type of contact dermatitis, which could be from the diaper itself, could be from soap or some sort of cleaning solution that the family is using to, bathe the child, or from maybe an irritant dermatitis from, a wet diaper being on the patient too long, or, some feces being in that area. So really that differentiate between a fungal infection and a contact. And the way that I do that differentiation in my own mind is I think fungal is going to be more infectious, right? So it's going to involve all those areas. It's going to spread from one part of the skin to the other. So it is going to involve the skin folds. And sometimes you're going to have those satellite lesions. So you're going to have a well-demarcated area, but those little red areas that are even outside that demarcated area. And that's going to be more of a fungal infection. Whereas something that is contact, usually it's just touching the skin, right? So it doesn't touch those skin folds. So that's going to be a little bit of a different pathway with things where we're going to think about any new sort of contact or some reason why the patient is getting this now at 6 or 9 or 10 months of age when they didn't have it earlier. Maybe they are being taken care of by a child care provider or not really getting the diaper changes frequently. Is that how you do it, Britt? Also divide it between that fungal and contact type of delineations?
Absolutely. And I think, that could help with our treatment, right? If it's just a contact thing and it's more of like a hygiene, we need to change diapers a little bit more frequently. We need to use more ointments and Vaseline. That can be one thing. But now it sounds like you're thinking this is pointing more in the fungal direction. Am I right?
Right. It's pretty bright red. I have those satellite lesions. I have those demarcations, and it does involve the skin folds. To me, this looks fungal.
And since you say it looks fungal, how would you go about managing this patient? What would you do from the urgent care to help give this poor little kid some relief?
Yeah, so it's actually a bunch of things. I want to make sure I tell the patient that. I'm going to have them actually told again and then write it down. But I used antifungal cream, something like a Lotrimin type of cream that I'd have them put on there several times a day. I want to make sure that they decrease the sort of milieu that fungus is like, which is sort of dark and moist and warm. And so the more that the patient can be without a diaper, the fact that we can actually, bathe and then really make sure that area is dry, making sure the patient does get frequent diaper changes, maybe before you put them down to bed, frequently during the day. All those things can be helpful not only in curing this fungus infection, but also helping, hopefully, to prevent further fungal infections. And then zinc oxide is something that people use also. But as far as like the acute episode of this, I would really start with an antifungal cream and just make sure that they do all those other things. Honestly, in my experience, I've had pretty good success with that. And, the ones that don't really respond to that, it's probably just because that patient is sitting in a warm, wet, dark diaper, and that fungus has the ultimate living environment.
All right, great, Mike. Thank you so much for joining us for these clinical images and being our urgent care master. Thank you so much, and let's go on to the rest of the show.
Thanks, Britt.
All right. I hope you guys enjoyed our clinical images. We had a great question in the chat by a Robert Bowman about the use of point-of-care ultrasound as like a supplemental diagnostic tool when working up fractures. Personally, I use point-of-care ultrasound to help with some reduction sometimes, especially if you got like a Colles and you want to, you don't have access to fluoroscopy or you're kind of sure that it's in. It's helpful to take like the linear probe, and you can see really well where that fracture line is, and if you've got a good smooth realignment. I think it could be sometimes difficult, when you're talking about the direction that the fracture needs to go if you're talking about a reduction, because you have like 3 planes, and it can be kind of hard unless you're really like thinking spatially with only one view, right? A 2-dimensional slice on the ultrasound to figure out the proper angles and stuff that you need. But overall, I think it's a great supplemental tool, but it doesn't really replace good old-fashioned X-ray for a lot of basic fracture identification. That was our images of the evening. Up next, we have an awesome chalk talk, although chalk is not being involved in this talk at all. Actually, it's the high-tech lightboard technology, but we're carrying over the tradition of writing on stuff and talking about it. So we'll join Britt and Sarah in the Lightroom.
All right, I know that we might not be using chalk, and for most of us on shift, it's a whiteboard. And here in the EMRAP studio, it's a lightboard. But really, I like this style because this is just on-shift teaching, just what you would do with residents while you're working a shift to explain a concept. And honestly, to be completely transparent, I asked Sarah to do this segment because I just had a baby and he doesn't poop. I mean, like, I'm talking 7 days, he doesn't poop. And so it kind of freaked me out, and I wanted to know about the management of infant constipation. So, Sarah, let's talk about normal poop, because it gets really confusing. There's colors that change that are normal. How does kind of normal poop progress?
Yeah, so I think in order to determine if a kid is constipated, it's really important to know what normal poops are first. So when babies are first born, within the first 24 to 48 hours, you want to see black stool. Now this should be pretty much the consistency of pudding. This is their meconium stool. Then over the next couple days, it's going to turn a dark green, and then by the end of the first week of life, it's going to progress to a yellow kind of seedy-like appearance, where that yellow stool kind of absorbs into the diaper and the little seeds are on top.
Okay, so we're going through kind of this whole spectrum of colors, like black, dark green, lime green, yellow. That to me kind of looks like mustard with seeds in it. Okay, so now I'm bringing my kid in, and it's a kid with constipation. They haven't pooped in 7 days. What are we expecting in the urgent care setting? What are we looking for on presentation? How are these kids going to present?
Yeah, so they usually present in one of 2 ways. They either come in, for the most part, asymptomatic, and the parent is just concerned about the frequency of the stool or the consistency of the stool, or they come in symptomatic. So your symptomatic kiddos are going to be...
So mind you, these are infants, right? This is like a 3-month-old.
Right. Yeah. So when we see adults and we see kids that are 5, 6, 7 years old, they usually present with abdominal pain.
Sure.
But this is not going to be the case in kids that are less than 1 because they can't tell you they have pain. So you're not going to have this. Instead, these kids are usually going to present with fussiness.
Okay.
Similarly, with nausea, like adults will get, or older children with constipation, you're not going to have that in these kiddos. They're going to end up having a decreased oral intake.
Okay.
Because they feel nauseous. They can also have vomiting. They can have abdominal distension. You can feel maybe a palpable mass in their left lower quadrant.
Okay.
Sometimes if you get super lucky, the parents will bring in the diaper
Okay.
and they'll show you these just big hard stools that are formed, or they'll be little balls. Sometimes it's clay-like,
Yeah.
and you can like actually
like really
mold it
firm.
with your fingers.
Yeah,
Yeah,
yeah.
like make creatures out of it.
The poo stone.
Yep. Yeah. that is not normal. You do not want that. What I always do too is I always check the actual anus to make sure there's no like fissures around the anus.
Right.
And every once in a while, you'll get a little surprise and you'll see a little gopher popping out. And then you actually see your little turd, and then you know for sure they're constipated.
All right. So you've done your exam. You've checked out this kid. You really think this is just good old constipation. How can we treat it? Like, really, how can we get these kids some relief? Because not pooping for 7 days, it's uncomfortable.
Right. Yeah. So the first line treatment in most of these kiddos is going to be dietary.
Okay.
So if they are already on solid foods, which usually begins between 4 and 6 months, you're going to increase their water intake. That's going to help a lot. We can also use prune juice and pear juice. That can be taken alone. It can be mixed in with formula. It can be mixed in with breast milk.
Got it.
You can also do any type of like kind of tummy rubbing to kind of help work that stool down.
The bicycle their legs.
Yeah, moving their legs, holding them upright. It will help with just gravitational forces of bringing that stool down.
Okay.
And then in the urgent care and ER settings, sometimes we'll just do a good old rectal temperature, and just putting that lube and that stimulation from the thermometer probe will actually help them take a dump.
Perfect. It helps stimulate the area and get things moving.
Yep.
What about formula? You know, sometimes it was recommended to me to change the formula. Should we be doing that from an urgent care setting? Should we kind of rely on our pediatrician to make that change?
Yeah, I usually let the pediatrician make that change,
Okay.
because there are different formulas based upon whether or not the child needs to gain weight, and
Right.
changing formula frequently can actually cause other side effects such as colic.
Okay. What about enemas, suppositories? What if we're getting desperate? Like this kid, we're going on 8 days of no poop.
Right.
What are we going to do?
Yeah, so your second line treatment, if you want to actually use a medication, is going to be glycerin chips or glycerin suppositories.
Okay.
That is the one medication that is safe to use in children as a suppository. Enemas are not used in children that are less than 2 years old, because it can cause hyperphosphatemia.
Okay.
So it can make your phosphate go up.
So
we
no
do not use them.
enemas in under 2 years old.
Right.
Okay.
Yeah.
Cool. So we do these things and we think this kid just has constipation. But what are some red flags when we're worried that this constipation just is something else? It's a little bit more than just constipation. What are some of the red flags that we need to be looking for?
Yeah, so if a child is having tons of vomiting, they're not being able to tolerate any oral intake, their belly is just super distended, where you feel like there's just a ton of stool in there where they need to at least be x-rayed or be admitted for a clean out, or like with Go Lightly or lactulose, then those are some reasons to go ahead and admit them. And then as usual with many conditions, just for pain control. If they're super uncomfortable and fussy, then it's fine to send them to the ER.
So what are some of the diagnoses when it's not just constipation that we absolutely cannot miss?
Yes, so some of the things that you need to make sure that you're not missing is something called Hirschsprung's disease.
Yes, I remember this.
So that is aganglionic megacolon. So they're missing the actual neurovascular supply, the neurologic supply of the bowel, so that it doesn't move through like it should. They end up kind of closing off down there, and then they can't push their stool out.
Now, the way that I remember this disease is that they don't pass meconium in kind of the first 24, 48 hours. So shouldn't this be something more that we see in like the first couple weeks of life?
Yeah, generally it is caught early on, but we do have children that go to age 2, 3 with just constipation, and then we end up finding out later that, you know, they get the diagnosis of Hirschsprung's disease.
Okay, so what else can I not miss with a kid with constipation?
So hypothyroidism.
I'm gonna be completely honest, that has never been on my differential for constipation.
Yeah. And that will usually come with, you know, all the thyroid symptoms.
Okay.
You know, they're tired, they're fatigued, they're just not as perky. And kids, they won't be feeding as well, so they actually may have poor weight gain instead of being more overweight like an adult.
Oh, okay. That's a good thing to look out for. And then what else can I not miss?
So your last thing is going to be something that is more acute in nature.
Okay.
And that's going to be botulism toxicity.
But this is going to come with other symptoms, right?
Yes. So they should have like a flaccid paralysis. Sometimes they'll end up with ptosis. They'll end up with some ocular palsies.
But it's my understanding that sometimes with botulism, constipation might be the first presenting symptom.
Yeah.
Cool. So good physical exam on this kid.
Yeah. Yeah, absolutely.
All right. This was super helpful for me. Obviously, like really helpful for me personally as a mom, because my kid was definitely dealing with a lot of constipation. I think this is really helpful knowing that we can increase some water, but not till food's introduced. So 4 to 6 months-ish, glycerin suppositories, prunes, pears, and then these really concerning diagnoses that we cannot miss.
Yeah, and then sometimes in conjunction with GI, you may be able to start Miralax or lactulose as well.
Awesome. Okay, so our next segment is going to be on peds foreign body removals, because kids, they really just like to stick things in their nose and in their ear, and we have to go fishing for them and figure out how to get these things out. So let's take a look at that next segment.
All right, Ilene, kids love shoving stuff in places, nose, ears. I have to be honest with you, I absolutely hate when kids come in with this. It's never fun. Everyone's always kicking, screaming, crying. You think like you can show up and be like the immediate hero, get this foreign body out. I feel like it doesn't go that well for me. I don't know, what's your experience? You're a lot better at this than I am.
Noses I kind of like. Ears are a little bit more difficult for me.
Okay, well, you've got some tips and tricks. Hopefully we've got some foreign bodies in places, and hopefully we can learn a little bit about the best way to take them out. I think wanted to start with the nose here. We've got this beautiful, a little bit older child, skeletized, but got the classic gummy bear stuck in the nose. I feel like I've seen a few of these in my time already.
Many of us have removed gummy bears. And, you know, the place that I like to start is with having the child blow it out themselves. If you have an older cooperative child who can do it, which is of course not the typical child that puts something in their nose to start with, but there is an alternative, which is to have the parent that accompanies the child blow it out for them. So if the kid is older and for some reason decided that they would put something in their nose but is mature enough to blow it out, what you can do is occlude the other nostril, the unaffected nostril, and then just have them blow. And this works best on a foreign body that's fully occluded, because all of that pressure is just going to blow it out.
Little cannonball effect, just, you know.
Right.
I feel like if you have, that's got to be an awkward conversation if you have a kid that age, though. You know, it's like you put it up there, why don't you just blow it out yourself? You know?
Oh, not awkward at all. They love it. They love it. They're so into it. But usually what is awkward is that the parent often has to do it. And to do that, what you need to do is have the parent blow in the mouth as if they're doing mouth-to-mouth resuscitation while you occlude the unaffected nostril, and then have the mom or dad or whatever caregiver is willing to do it deliver a long, slow breath with as much force as they can to try to get that thing to pop out. So I'm going to have you show us.
Okay, so the idea here is you're basically giving this like a rescue breath to shoot it out the nostril. You're having the kid do anything special, or just kind of like sit there and tolerate a very uncomfortable moment?
Whatever you can have the kid do. Okay. Yes, absolutely.
Is there any other special preparations you're telling the parent or the volunteer in this situation who's going to be blowing in, or you're telling them watch out for like vomit, gross stuff coming out? How's that?
Absolutely. So they have to make a seal around the mouth. It has to be fully occlusive. You really need to be a cheerleader. The risk of barotrauma from this is infinitesimally small, but every parent is worried that they're going to pop their kid's lung. So you really have to stand there, channel whatever tiny shred of inner cheerleader that you have, and be like, you got this, come on, keep blowing. And if you do it a couple times, they actually will get kind of into it. The other thing that I've seen parents do is if you just kind of take little uric here and you go straight like this, you are going to cover up the nary with your cheek. So you have to kind of tilt a little bit so there is a clear space for that foreign body to come out. And finally, there's a lot of snot involved. So I would always have some Kleenex, towels, something at hand. Typically, the foreign body comes out with a bunch of snot behind it. And the weird thing is, and I'll never understand this, is a lot of parents, when the foreign body comes out and they've been successful, they will start to cry as if they have just saved their child from certain death. And so you need the Kleenex for both the snot from the child and the snot from the crying parent.
Just a gross situation. All right, so let's actually do this. All right, so I'm gonna tilt the head back, and then you would be the one including the other nare. You'd have the kid or
so
parent.
I'll stand here. I'll include this
and
nare.
just give a nice big.
You
just
got
a big
this.
rescue breath, or just.
Yeah, and I'm gonna. You got this. You got it. Yep. There
Wow,
you go.
shot right out.
Amazing. Right. You can try using a bag valve mask if there's not a parent who will do this. But if a parent does it, it's about 60% effective. It's actually
That's a lot
really
higher
good
than I
thing to
thought.
do, right?
60% for that.
Yes, much less if you're doing the bag valve mask. So if you can get a parent to do it, much better.
Wow. All right. So what if that doesn't work? So you go to that's your plan A 90% of the time, you'd say, or is there any situation you're like, we're going to skip this and we're going to go right to another option?
I usually will try that first, but if there is a large clear space, like there's a big hole where I know the air is going to come out, I do sort of expect that this is probably not going to work as well. But I have another technique that I love for that, and that's passing a balloon beyond the foreign body, blowing the balloon up, and then pulling out the foreign body with the inflated balloon. You can do this with a Foley catheter, and 6 French Foley is typically the smallest Foley with a balloon. Or there are a number of these ballooned devices where you can just kind of connect it up to a syringe and then the balloon will blow up like this.
Nice.
Something that's a little bit nice to do beforehand is to deliver some anesthetic and some vasoconstrictor to the nose. Giving the vasoconstrictor will give you a little bit more clear space, more room to get it out. And obviously, this is uncomfortable at best. I actually did it once for a demonstration. I was shocked how blindingly painful it was. So if you can give some anesthetic as well, maybe a little lidocaine with epi or something like that, it can be helpful. But what you're going to do is you're going to take a look in, you're going to find the clear space. You're going to go ahead and pass your balloon beyond the foreign body, and boom,
Boom.
There you go. Oh, all right. Well, what
That's
I was
good foreign body.
what I was going to say is the one caveat is that you don't want it to go in the mouth. But obviously, you have proved me wrong.
We're past that point. And so, to clarify, the anesthetic or the vasoconstrictor, you don't want to give those when you're doing the like projectile motion, right? Because you're trying to have it nicely seated in there to get that air pressure. So if that doesn't work, then you start administering those things?
That's typically my practice. And I was joking a little bit about not wanting it to go in the mouth, but I do have to say we do a lot of procedures like this on kids laying down, or at least semi-supine, because we're trying to immobilize them and it's sort of hard to do. But do remember, the kid is probably going to be screaming. They're probably going to have a wide open mouth. And when that foreign body pops out, it's going to pop right into that open mouth. And you're going to convert an inconvenient foreign body to a life-threatening one. So if you can do it with the kid sitting up, leaning forward a little bit, you can save yourself a trip to the OR for...
Keep the transfer right there. Immediately. Immediately. Don't need a paddle for that one.
Exactly.
All right. Awesome. Well, as I bring out our next orifice, we got our ear here with our foreign body.
Oh, thank goodness it's an ear.
Yeah, you never know what's underneath the table here.
I did not know what you were going to get out, yes.
So we were talking about the risk of it going into the mouth. I feel like kids that have stuff in their ears, especially if it's something squirmy or gross, kicking around, really hard to get them down. Do you sedate any of these kids?
Sometimes I do. I do have to say, ear foreign bodies are pretty predictable. So you look in the ear, and once you've done this a couple times, you know within a few seconds if there is a high likelihood of getting it out or a low likelihood, right? If you have something that you can grab, you have a little corner, it's kind of asymmetric, you can sort of envision it's a little bit, closer to you, that you're probably going to be able to get out. On the other hand, if you have a very smooth bead that is deeply, deeply embedded to the point that you're wondering if it's already partially through the tympanic membrane, and you're thinking, I can never get this out, you probably can't. And it's not a power of positive thinking kind of lecture here. This isn't Dianetics. I'm just saying that we are very good at predicting whether or not we can get this out or not. And the fact of the matter is, once you try twice and fail, your risk of complications goes up precipitously and you are probably not going to get it out. And in most scenarios, your smooth bead that's sitting in there, that would be a perfect example of something that would be difficult to get out. That is also something that can wait for next day removal by a specialist that has a lot of equipment that we may not have at our disposal.
That's a great point. You can just, if you're working in an area, you have a call panel, like in your urgent care's catchment area that there is an otolaryngologist that you could just call and set them up with that. You don't even need to transfer the patient to the emergency department. You might be able to get a next day appointment or something. That's great.
And in fact, it might be better not to, because when I have one of these in the emergency department, it's not like the otolaryngologist is typically coming in. It's not an emergent thing. And they have a lot of equipment in their office that I don't have to provide them in the emergency department. So they would rather do it in their office.
Yeah, there's nothing worse than working in the emergency department on being on the receiving end of that transfer, where now the parent and the patient's expectation is we're going to get it out, and really our ENT colleague is like, that sounds great to see tomorrow morning.
Exactly.
And then it's like a whole waste. And in terms of stuff that can't wait, though, are there any foreign bodies of the ear or any, like nose or anywhere else that you are really going to try a valiant effort to get it out because it's dangerous to keep in there?
Well, obviously the big one that we alluded to before when we were talking about the esophagus is that button battery, and the same issue you have with a button battery in the esophagus causing liquefaction necrosis, that applies to the ear and the nose as well. So those do need to come out. They do need to come out quickly. We will talk a little bit about irrigation. I mean, that is one thing that you can do to get something out of an ear, is you can irrigate it with tons of water, and often the foreign body will come out. It's recommended not to do that if it's a button battery, because that will release a lot of the alkaline chemicals from the battery. So with a button battery, what you want to do is remove that as quickly as possible, dry, and then after you've removed it from the ear or the nose, irrigate the cavity to try to get rid of those residual chemicals. But that actually is an emergency, and if you can't get that out, that is something that I would transfer emergently. Live insects, not ideal to have in your ear.
Not ideal at all.
Really, really uncomfortable.
Gross.
Could you leave that to the next day if you killed the insect by putting something like lidocaine or mineral oil in the ear to kill the insect? It's not recommended, but you probably could, particularly if you started an antibiotic drop to prophylax against otitis externa. And I would probably do that if I left any organic material in the ear overnight for a next morning ENT consult.
That makes sense. You think it's hard to convince the parent that you're not prescribing antibiotics to a kid and try discharging them with a cockroach still in their ear. That's a fun discharge conversation, but that makes total sense. So, like you've got the foreign body in the ear. There's a most common place you were talking about before that these foreign bodies tend to end up. What are some of the tools that you like to do or techniques you like to try to get it out?
Yeah, so we talked about irrigation. Usually these foreign bodies end up sort of right where the soft tissue portion meets the bony portion. So it's about a third of the way into the ear. So you do tend to have a little bit of space to work with. One thing that I really like are these lighted curettes. They're super fun. You can convince the kids that they're toys. And basically what you do with this is you have your light.
Yeah, this one's got like a scope, it's got a handle, it's not legal in the state of California, it's got, too many attachments on it.
I have a permit, don't worry.
Okay.
I have a
All right,
permit.
perfect.
But this is great because you don't need like 16 hands to hold your light source and then try to, go through the magnifying area. This will do everything for you. Here's your magnifier, here's your light source, and then here's your curette. It's great for wax. I love this for wax. A little bit harder for foreign bodies, but sometimes it can work. And so if you go in here, there you go, and
Boom.
Dude, and all you had to do was cut the head in half.
Yeah, just cut them in half, and then you can get right in there. It makes it real easy. They sell those with night vision as well, attachments and silencers, for those really difficult to get objects in there. That's awesome. I've never actually used one of these before. It's way easier than the traditional curette with the lighting and the magnifier. That's great. Yeah. So what do you do if you don't have that available?
Well, there's one other technique that's described using some type of a glue and the back end of a cotton tip swab. And that's basically...
And we're talking about skin adhesive here, not like, Elmer's glue or something.
Elmer's might not work as well. You might want to try some crazy glue, but typically what we have available to us is skin adhesive, and you're going to take a little bit of it, you're going to put it on the back of your cotton tip swab.
Okay.
And then, I've never done this with a gummy bear before, so I can't guarantee it's going to work. But then you're going to adhere it to the object. I am not great at this technique, and I think it's a matter of patience. You really have to sit here for a good 30 seconds while it actually adheres, and theoretically, knocked it out.
Just pops out.
But theoretically, it should glue itself to the foreign body, and you should be able to pull the entire complex out. You obviously don't want to touch the external auditory canal. That's a little bit embarrassing to explain to the parents that not only are they going to have the foreign body removed the next day, but they're also going to have your entire cotton tip swab.
It's hard to sleep with a giant, Q-tip sticking out of your ear as well.
It is.
It's really got to be a belly sleeper in that situation.
Some people like to use one of these otoscope tips and kind of go through it just to make sure that they're guided a little bit.
That's perfect. I've personally done this one time that it's been successful. Just the same problem. It's like hard to adhere, and I think I'm just not patient. I feel like that the same way. Well, that's awesome. Thanks for working us through all of these different techniques of getting foreign bodies out of the ears. Any last minute tips or things that like you found to be really helpful with coaching the patient, coaching the parent, besides the extra tissues for the tears after the saving moment?
I think the biggest thing is just being humble.
Okay.
I think that, in urgent care, in emergency medicine, we do a lot of things that consultants usually do really, really well, and often more than the consultants do when it's basic stuff that comes in on a near daily basis. Ear foreign bodies, we don't do as well. We have a higher complication rate, and I just want to emphasize how important it is to be humble enough to say, it looked like it was going to be tough. I tried a couple times, it's not working, and somebody else can do this tomorrow.
That's wonderful. Well, I think that's enough for foreign body removal right now. Thanks for walking us through these procedures. This is great. I got some gummy bears in my ears right now. A little hard time. Next up, we're going to have Mel Herbert over at the Lightboard walking us through some papers of the month. I think we got 3 papers for you to change your urgent care practice.
Thank you.
All right, let's do 3 papers. Now, I'd say one thing before we begin. There's not a lot of primary literature in urgent care. We got some papers today from the Journal of Urgent Care Medicine and from Josh Russell, who is the editor-in-chief there. But it's time to step up the game, urgent care people. It's time to start doing some research because most of the stuff that we talk about is extrapolated from the emergency department. So the first paper is actually not a study, it is a review article, and it goes through a case. And here's the case. A 4-year-old Hispanic child is found flailing in the pool, coughing, no apparent injuries. He vomits once, mostly water. He's otherwise well. And then he comes to your urgent care setting. So the first thing to talk about here in this review article is that now there's really 2 types of drowning we talk about now. Fatal drowning and non-fatal drowning. There was a much more complicated nomenclature that we used. And drowning has really simplified, and this is not the only area. We used to talk about freshwater drowning and saltwater drowning, and it turns out that physiologically these are just the same. You cannot inhale enough fresh water or salt water to have significant changes in your blood chemistry. You basically are alive or you're dead, you're sick or you're not sick is how we think about drowning now. So there is this very complicated algorithm, but it's not that complicated when you look at it. But basically it says this, let me simplify it for you. If you are well, and well is defined as you didn't crack your head, nothing else bad happened to you, and you're awake and alert and oriented and you're not hypoxic, then these people do great. And you can watch them for a while. There's a magic 4 hours in this review article. Compendium talks about the same thing. But basically if you're well and you watch them for 4 hours, it is very unlikely that you're going to crash and burn later on. So the simplified part of this here is that kids that look good, they can go home. So this kid actually had a chest x-ray at the urgent care center that showed a little bit of bilateral hyaladenopathy and infiltrates, otherwise looked well. They got transferred to the Children's Hospital. They watched him overnight and they had no complications. You might get chest x-rays that look like this, a little bit fuzzy. There is some question about whether you need to even do a chest x-ray at all if the child looks well, because it turns out that the vast majority of cases of drowning, there really is, that glottis just shuts, and somebody notices that the kid is flailing, pulls them out, no water has gone into the lung or very little, and they cough and they splutter. And if you watch them for a while, non-hypoxic, otherwise well, the vast, overwhelming majority of these, what we used to call near drowning events, really don't result in anything bad. So I'll throw it to our peds experts. Got anything to add to that in your urgent care setting? Looks good, tastes great, setting well, watch them for a while, send them home?
I think the other question to ask is, what happened and why did this kid drown? A lot of kids under 1 just drown in the bathtub, or maybe it's a toddler that wandered into the family pool and that's fine. But when you're looking at something like an older child or an adolescent, unless for some reason they really just don't know how to swim and wandered into the pool, The other thing to look for is there some concomitant injury? Like, is there an adolescent who also has substances on board? Could they have fallen and had a head trauma or a C-spine injury? So it may be that you're not transferring them for the drowning itself, but you may be transferring them for a workup of, was there a seizure? Is there altered mental status? Is there head or neck trauma? Not common, but particularly in the adolescent or adult, I might consider that.
Good point. I got to tell you, I am amazed at how quickly little kids who don't know how to swim will fall in a pool and start to flail. It's amazing. You turn to get the hamburger and then you turn back, and why is the child flailing in the pool? Pools are terrifying and you should be terrified of them. All right, let's do this study. This is another one from the Journal of Urgent Care Medicine. I'm not going to say this is a great study, but I think it brings up an important point. This was 3 peds urgent cares. And what they looked at was a series of cases, about 2,000 cases, of kids that were otherwise well, no other significant problems, didn't look sick, who had basically cellulitis, and how long did they get antimicrobials for? And it turned out that over 40% of the time, antimicrobials were given for more than 7 days for an uncomplicated skin and soft tissue infection. And all of the guidelines say that's too long, that 5 days to 7 days is enough. Now, most of these are made up, right? It's never 5.5 days. It's never 6 days. You couldn't give it for 4 days, forget it. But in almost all of the studies that come out about infectious disease for these kind of uncomplicated infections, whether it's the throat, whether it's the skin, wherever it is, the shorter we do the courses of antibiotics, it still works. So 7 days, 10 days, sometimes these kids were given 14, 21-day courses, is associated with a lot more side effects and no significant improvement. So again, back to our peds experts, an uncomplicated cellulitis in a kid, what's the duration of antimicrobials you're giving, and are you doing anything else?
Yeah, I think generally I usually do about 7 days or so, as long as an infection doesn't look terrible, and then plus minus having them come back in like a day or two for a recheck is usually what I do. I never do 14 days. If there's something that's concerning that they need 14 days, then I think they really need to go to the ER if it looks that bad.
All right, let's do the last one then. And this was an ER study, which we're going to try and extrapolate to the urgent care setting. And I actually got Josh Russell's opinion about this. But this study was basically, what is the chance of bacteremia in kids who come in with fever and lower extremity pain? And lower extremity pain was defined as a kid old enough to say, my leg really hurts and I have a fever. A kid that has an antalgic gait, can't walk properly, has a painful gait. Or a caregiver that really knew the kid well, saying there's something up with this kid's leg and they've got a fever. So it was a single site ED. So the extrapolatability of this to other places is unclear. So they had fever, they had this lower extremity pain, they had 510 usable blood cultures, and they had a 14% positivity rate, about a 1 in 7 positivity rate. MRSA, other staph were the most common things. And they said the things that make it more likely that you're going to get a positive blood culture is that you've got a localizing finding, it really is swollen in their knee, or their CRP is really high. So the point of this was, for me, a kid who has fever plus limp, fever plus I've got pain in my leg, you should have some anxiety about that, because although many of these might be a toxic synovitis, a post-viral syndrome, that there is a significant percent of these kids that will have something worse than that. So what is an appropriate workup in the average urgent care setting? And maybe you'll do an x-ray, maybe it's you'll see something on there. Usually you don't see infectious things, you might see a cancer or something else. But the things that you would normally do in the emergency department during a lot of CRPs, maybe doing some imaging, putting needles in, you can't do at most urgent care centers. So I asked Josh Russell that question, and he answered the same thing, that for most of these kind of workups, he doesn't feel like most urgent cares can do them, and certainly none of the urgent cares that he's worked in, and again, Josh is the editor of the Journal of Urgent Care Medicine with lots of experience here, he said almost no urgent care he's ever worked in has the ability to do a blood culture, because that's suggesting somebody that's sicker than probably should be looked after in the urgent care, and follow-up could be an issue. So if you're drawing a blood culture, in most cases, you probably should be sending them to the ER. So again, back to our peds experts. Ilene, you said before that there probably are some kids that you'd be happy to send home. But are there kids you're happy to send home without doing CRPs, ESR, and other inflammatory markers, just by looking at them and saying, febrile kid, but looks good, got a bit of a limp or a bit of a sore leg, but I'm pretty happy that's nothing bad?
I feel like kids complain about lower extremity pain quite a bit, not to the point that they can't walk, but are complaining of some pain. So I do think that if you had the capability to do the blood culture, to do the CRP, the SED rate, and a great exam, that might be somebody who, if everything is normal, obviously you're not going to have the blood culture result right away. They could potentially go home. But I do think that there is a lot of value in doing those labs and in having a period of observation. A lot of these kids in the study had septic arthritis, they had osteo, they had pyomyositis, and I'm not worried about anyone missing that. You're going to see an irritable joint. You're going to see focal tenderness to palpation of an area of a bone. But there was one kid in the study with toxic shock, and we know things like meningococcemia can present with lower extremity pain. So those kids are the ones that you're going to want to really undress, check over for rashes, look for capillary refill, watch for a little while you're getting those labs. And if that's not something that you have the capability to do, then I would have a low threshold for transfer.
Excellent. Sarah, anything to add to that?
Yeah, I agree. It depends on what your capability and how much time you have as well at urgent care, how much time you're willing to spend with this one patient, because you do have other people that you have to take care of at the same time. And so if it's going to be a big workup where you need like a hip ultrasound and you need to tap a joint, then those ones and send it to the ER for workup.
Excellent. All right, well that's our 3 papers for the night. I'm going to turf it back to the main studio, and I think we're going to do some summary and a few more questions. Go.
Yes. I learned so much in this segment. I took notes because I am just having these peds specialists is just so helpful. And I think peds can be really intimidating sometimes. Like we said from the beginning, we're not used to seeing kids quite as often. They don't come into the ER or the urgent care setting quite as often, which is good that we don't see a lot of sick kids. But when we do, it can be kind of scary. So I'm so glad you guys were here to kind of address some of these questions. First and foremost, go ahead.
Before we jump into the pearls, Mel mentioned Josh Russell a few times.
Who is that guy?
Hey, Josh. So he's the editor-in-chief of the Journal of Urgent Care Medicine. He's actually joining the UC Max team. It'll be great to have him.
Woo!
So you'll hear his name a lot more frequently. It'll be really fun. So
We're
I saw you in
excited
the chat. How are you doing?
All right, so
What did we learn?
the things that I learned, and please add on because there was so much here, but those tongue lacerations, I think that they can look really scary and the kids like bleeding all over the place. But if you can get bleeding controlled, if it's less than 2 centimeters, not gaping and not through like the tip of the tongue, probably okay to just let it do its thing. It might look kind of funky for a while it's healing. It's gonna turn out just fine. All right, I also learned some of those foreign bodies, those really need to go. Those button batteries, esophagus, ears, nose, they gotta go. The ears, I agree with Ilene. I hate taking things out of ears because one, the kid hates it. I don't have a great success rate, to be completely honest, with getting them out. And you just can never tell how close you are to the TM. And if you get a little too close to that TM and now you have a perforation in a foreign body, it's just a really bad day for that kid and for you. So sounds like 1-2 attempts, doesn't work, send it out, have ENT work on it. I also learned that the mother's kiss, try it first, pretty effective. Have a box of tissues ready.
I think it's also sometimes called the father's sigh. I think that's also,
And then constipation. Sarah, thank you so much for doing this segment specifically with my child in mind, because I think it can be really concerning, especially as a first-time parent or multiple-time parent. Your kid just doesn't poop, right? That's just like they poop, they eat. That's one of the main functions, and your kid's not doing it. It's scary. So, you know, adding water if it's safe, a safe age, 4 to 6 months once we start adding some foods. Changing the formula, we're probably gonna leave that to the pediatrician. And man, those glycerin suppositories, they work.
I think it's so funny the way you phrase it. It's like, well, their main function is one of the 2 things that you do. That's it.
They eat and they poop and they sleep and then they cry. And if they're not doing one of those things,
It's concerning.
it's concerning. All right, Mel, I think you were getting some questions from
I
the
got
audience.
some more questions. So you were talking about button bastry ingestions, and somebody asked about the use of honey. Is there something magic about you're transporting and you're waiting and you give them honey, or is it just to be nice? You're going to die. Have some honey.
Gosh.
Yeah, so we were actually just talking about this before the show. We had forgotten to mention it, so I'm glad they asked that question. That yes, you can give 2 teaspoonfuls of honey to kind of neutralize the alkali.
And there's a new recommendation to give sucralfate as well. So as long as it's not going to delay your transport, it's not going to delay your care, giving honey, giving sucralfate supposedly will like coat everything and cause less damage to occur.
But
Just a
over 1 year.
Full of honey.
Honey over 1 year, right?
And battery go down.
With or without botulinum spores. With or without.
Yeah. Well, you want it with so that it's the esophagus is paralyzed when the endoscopy
down.
occurs. Yeah.
And the intubation's way easier.
exactly,
You don't have to ask what the paralytic is.
Is that a thing like you're rural medicine, you're way out there and it's going to be a long transport time and you're on the phone with mum and you're like, give the kid some honey while we're waiting to get the ambulance 5 hours to come get you? Seems
Perfect.
reasonable?
Yeah.
Yeah.
Reasonable.
All right.
Costs, it doesn't cost much. Most people have it. Seems to be helpful.
Excellent. All right, next one is about peds fever guidelines. Mind blown. Now we're down to 21 days. What is the world going to? The person asked the question with these peds fever guidelines, what inflammatory markers are they suggesting in that age group, in that sort of 21 to 28 day where you're going to decide, I don't need to do much else? Is it CRP? Is it procalcitonin? Is it hair of newt? What is it?
Yes, no. It's usually CRP, procalcitonin, and ANC. But there are places that don't have procalcitonin. Obviously, there are places that don't have CRP. We didn't have procalcitonin until relatively recently. And so you can use a temperature above 38.5, so a slightly higher temperature as a surrogate marker for procalcitonin if you don't have that available without a lot of loss in your sensitivity. Actually, without any loss in your sensitivity, really.
So let me ask you, for years we've been watching this literature and I haven't looked at it for a few years, but it wasn't clear that any of these inflammatory markers were better than you as a smart pediatrician looking at the person saying, I think they're fine. Are we at the point now where we can definitively say this is adding something useful to your clinical gestalt without making you do a lot of workups you didn't need to do?
I would say there's no single inflammatory marker that's good enough to necessarily say you do or don't need to do anything. That having been said, using this bundle of inflammatory markers, while it's never going to be better than anybody's clinical gestalt, you've already clinically said, hey, I think this kid is well. I'm separating out the febrile, well-appearing children who meet the inclusion criteria, they're otherwise healthy, all of that stuff, for these guidelines. And let me just pick out the few that my clinical gestalt is missing who might have something serious.
I think that's such an important point because, the urgent cares that I've worked at can't send a CRP. No one's running like an ESR, but it can definitely put a thermometer in a kid's butt. So, knowing that that's like a tool that you have that doesn't really impact your sensitivity that much. And I mean, I'm sure as this literature continues to evolve, we're going to see 21 days become 14 days or like lower. So that's
They're
like really
just
helpful
trying to get rid of your favorite procedure, Ilene.
Seriously, I also should mention, sorry, before I forget, they do use a slightly higher ANC. So if you're using that modified criteria and you're using the temperature instead of the procalcitonin, you're going to use a slightly higher absolute neutrophil count.
And I mean, this literature has changed so much. Like, there's been the step-by-step and so many different approaches. That paper that we referenced, and we'll put that in the show notes, has the whole and every algorithm for all of these cohorts of ages, that 8 to 21, 21 to 28, and it's pretty straightforward and easy to use. Now, whether or not you have those inflammatory markers or can send the CSF in an urgent care, that's debatable, but the guidelines are pretty straightforward. Those algorithms are pretty easy to use, and I think it's taking a lot of the guesswork out of this, especially for us that aren't PEM, that just need if this, do that. They're very helpful.
Let's go back again for a second. Somebody wanted you to repeat how much honey for that button battery?
It should be 2 teaspoons.
2 teaspoons? What if they really want more honey? Can they have some more?
I don't know.
What if it's 2 button berries?
Ah.
It's a big button
Yeah, have another button battery, 2 more teaspoons.
With
Or-
that
battery.
Some of those recommendations are so crazy. It's like 2 teaspoons. It's like, what if they were eating a bunch of
Yeah.
honey right before? Like,
Well,
who cares?
yeah,
It's like,
maybe,
like at least 2 seems
At
reasonable to me.
least
But
2.
yeah.
You can have more if your heart desires.
They are so funny. Like, I'm sure there's a double-blind randomized trial on how many doses of honey you had to get.
Yes.
Somebody talked about the fact that we showed an X-ray, and actually I was looking at the side. It looked to me like mostly a buccal fracture. Was there more to it than that?
Is this for the transfer versus keep?
Yeah.
Yes.
There was more to it than just a buckle.
There was
There
a
was.
green stick on the side.
Yes.
So it was
It looked
buckle
like-
and a green stick.
It looked like one bone had a buckle,
Yep.
and then the other bone had a green stick, which is a fracture through one cortex where the other cortex is intact.
Yep.
And even though buccal fractures tend to be more visible on X-ray and they kind of catch your eye most of the time, buccal fractures are incredibly stable. They don't need to see an orthopedist. There are a lot of people that don't even feel like you need to immobilize them at all. Or if you do, you can use a removable splint. Very, very easy to manage. Green stick fractures, on the other hand, are innocuous appearing, on X-ray. And if you remember looking at that X-ray, you kind of had to squint and turn your head to see that tiny break in the cortex. These require much more cautious follow-up because they can angulate, they can break through the other cortex and complete, and these really do need to see an orthopedist and be immobilized.
One of my favorite studies in the last few years on buccal fractures, I think it was out of the UK, they wanted to compare not doing anything versus immobilization, but their ethics board was like, you can't do nothing. So they're like, okay, well, what if we just wrapped them in gauze and put some tape on it? You know, effectively nothing.
Band-Aid.
Yeah, exactly, right? Because we're like, all right, well, you're doing so, and identical outcomes. So it's like a pretty nice to know thing, especially you're getting slammed, you don't have the casting material, splinting material, whatever, knowing that those will do great no matter what happens.
I have a question about the green stick. When do you need to push on those? Like, what degree of angulation do we care about where we actually should reduce them? Is there an angulation?
There is.
I do not know the number off the top of my head.
I think the problem is it depends. It depends on a few issues. It depends where it is in the bone and how old the child is. So the younger the child, the more angulation they'll tolerate.
Right.
And the more potential for growth in that area of the bone, the more angulation they'll tolerate. So if you're looking at a distal radius in like a preschool age child, you can often tolerate 15, even 20 degrees of angulation, whereas a midshaft radius in a 13-year-old, you're going to tolerate a lot less.
Got it.
So it really depends on the particular age and the particular bone.
20% sounds like so much.
I know.
Like, but no, that's very helpful.
Another big question. How much prune juice for constipation?
There's not really a set number for that. Usually, I think most of us will tell them to add in like a teaspoonful or so to like a bottle, like an 8-ounce bottle of whatever they're drinking. I know out where I work, we actually have a bakery that sells prune cupcakes. So with like the chocolate frosting, they'll do prune juice, and then it works for constipation. So
And the kid gets to eat a cupcake.
and they get a chocolate cupcake. They think it's chocolate.
They do a lot of birthdays at the retirement home. Big sale on those.
That's awesome. And then somebody was noting, you were talking about ultrasound for fractures, and again, old guy, my head is blown. When I was a young lad, ultrasound was fluid, no fluid. That's all you did, fluid, no fluid. Now you're doing fractures. And there's a New England Journal article actually from Australia, so it's got to be good, of about 270 kids between 5 and 15. Ultrasound versus standard x-rays and stuff, no difference in outcome. So ultrasound, if you know how to do it, apparently is a thing for fractures. Who knew?
Yeah,
Absolutely.
Great, great for finding some subtle ones. But, you know, like again, the takeaway though is if you're having issues with this, like a lot of the decisions, operative, non-operative, what you might end up doing are based on angles and other measurements from the radiographs. So that's like the one downside. You know, like you have to be able to follow that up or know how to follow somebody up with.
I think that's all the questions. David from Kenya is saying hi to Brittany. Hi, Brittany.
Oh, hi.
Stuart saying
You're
always-
up at such an odd
I
hour.
know, it's so late.
There's a huge time difference.
And Stuart Swardron says he always takes 2 teaspoons of honey before bedtime anyway. So
Oh,
that's
that's
very important.
sweet.
Just in case there's a barren button battery swallowing in your sleep. Yeah.
And I have a quick update.
Yes.
Our next grand rounds.
Yes.
Next one, so remember we do urgent care and then we do EM. So our next EM grand rounds is July 5th. Super excited about it. We've got an awesome team. And it won't all be peds, but it is going to be a different style. So stay tuned.
An easy way to remember that is the first Wednesday of every month.
Yeah, we decided that would be easier.
Yeah, so first Wednesday of every month. Keep track. And please join us if you know anybody who is matriculating into EM residency on Thursday, June 8th. We're going to do our residency jumpstart. So we'll love to see you there. Same place, same time, 5 p.m. on the YouTube channel. Click on the doobly-doo. Be good.
And Ken, last one, said, you said some references and stuff are going to be in the show notes.
Yes.
Where are they?
When these so this is streaming through YouTube, it then will, in about a few days, will go on the EMRAP HD site. And there, just like a lot of the other podcasts or different shows, in that summary will be the show notes and links to all the paper and literature we referenced tonight.
And we'll try to update the YouTube doobly-doo as well, hopefully, and we'll get some of those links in there for you.
Is that a real word?
It sounds pretty real to me. Doobly-doo? Sounds, I mean...
Sealed July
medical
5th.
And I think we have some people to thank, too. If
We have some people to thank. So from the production team, oops, did I go backwards? We've got our entire production team. They're amazing. I saw some shout outs to the bumpers that we have in those short videos. That's Josh. That's Bill. There's a whole AV team doing sound. And of course, to our amazing faculty, thank you so much.
Bye. See you on the next one, everybody.
Oh,